How many of your patients with lower back pain actually have a multifidus activation problem without you knowing it? Because at first glance, it might seem like everything is working correctly. The patient moves, performs the exercises, controls their position, and completes all the repetitions. However, beneath that movement, there could be a completely different neuromuscular pattern than the one you expect. And one of the muscles that can most easily go unnoticed is the multifidus. The multifidi play a fundamental role in the segmental control and stabilization of the lumbar spine. The problem is that they are deep, small muscles that are difficult to assess solely through observation or palpation. That is why a patient can seemingly perform an exercise well, while other more superficial muscles, such as the spinal erectors, are taking on most of the work. When we analyze muscle activation using surface electromyography, we find very important differences depending on the exercise we select. So, we are going to look at 5 exercises ordered from lowest to highest multifidus activation and how you could use them within a clinical progression. We start with the bilateral glute bridge, which generates approximately 40% of the maximum voluntary contraction, or MVC, of the multifidi. It is the exercise with the lowest activation in this ranking, but this does not mean it is a bad exercise. It can be interesting in initial phases as an introduction to stabilization work or for patients with limited load tolerance. We move up a level and find the bird dog, also known as the quadruped Superman, with approximately 46% MVC. Here we add the contralateral movement of the arm and leg, increasing the need to stabilize the spine while the limbs move. It is an especially interesting exercise when we are looking to work on lumbar control without introducing high loads yet. In third position, we find the single leg glute bridge, which reaches approximately 60% MVC. The difference compared to the bilateral bridge is significant. By removing one of the support points, we create a load asymmetry and increase the demand on the lumbar stabilizers to prevent the pelvis from rotating or losing its position. This makes it a good progression option for intermediate phases. And now we arrive at the exercises with the highest activation. The lumbar extension, combined with hip and arm extension, reaches approximately 87% MVC. In addition to a high demand on the lumbar extensors, the movement of the limbs introduces an additional component of rotation control. So the multifidi have to participate in a very significant way. And in first place, we find the lumbar extension with approximately 90% MVC. It is the exercise that produces the highest activation within this ranking and can be especially useful when we are looking for a high load on the multifidi in patients who already tolerate this type of exercise correctly. If we organize this data, we can establish a fairly simple progression. Start with the glute bridge and bird dog, advance to the unilateral bridge, and when the patient has sufficient tolerance, introduce the lumbar extension variations. But here is where the real clinical problem appears. These percentages are reference values. They do not mean that your patient is going to activate their multifidi exactly in this way. 2 patients can perform the same bird dog apparently with the same technique and present completely different muscular strategies. One may clearly increase the participation of the multifidi, and another may compensate by using superficial musculature. Pain, fatigue, motor experience, technique, or individual movement strategies can completely modify the muscular response. And that is where measuring changes the way you work. With surface electromyography, you can check what happens during the exercise, compare different variations, and discover which one actually manages to increase activation in that patient. Because the question shouldn't just be which exercise activates the multifidi the most according to the literature, but rather which exercise manages to activate them best in the person you have in front of you. Knowing this ranking can help you better select exercises and organize the progression, but measuring the muscular response allows you to know if that progression is actually working. If you want to discover how to use surface electromyography to identify activation deficits, detect compensations, and design exercise programs based on objective data, request information about endurance, and discover how to apply EMG in your clinical practice.